Hi, I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, in association with Atrion, we have a great opportunity to discuss supercharging bone tendon healing. I feel we have a superb panel. Many of them, all of them know each other, and many of you know them. And I think this is a great time for me to pass this over to Joe Abboud, who will moderate this evening's session.
Thanks, Ira. Thanks to Joey for having us on this platform to talk about something that to all attending and the panelists is very dear to our hearts, and that's rotator cuff disease and how to improve our outcomes and overall patient satisfaction. So I have an esteemed panel. I'm just going to go from my right to left here on the screen. Jovan, Laskovski, Brian Badman, Bill Levine, and Justin Smith. And I want to also thank Atrion for helping sponsor this evening tonight and discussion. So going to start off with Brian Badman, who's going to kick us off with this, and he's going to give us a little bit of sort of overview of rhodium. Before we do that, I'm going to talk about why is this topic important tonight. So we know that dating back to Lisa Gallett's papers as far as massive rotator cuff tears and recurrence of tears, that we have a high failure rate when we do rotator cuff surgery. And patients may feel better, but if you check their MRIs, a lot of times there's re-tears, partial re-tears, or they have recurrent tears down the road 10, 15 years later. And since I did the ASES Traveling Fellowship 2009, in 2009, Andy Carr was at the CESEC meeting in Madrid, Spain. And he stood up and said, we have all the widgets, all the gadgets to technically execute the operation, but we still lack in the biology. And, at that time, I thought that was a very fair statement. And I thought 15 years later, we would have essentially solved that problem, but we still haven't. And I still think we have a lot of work to do. And there's been an explosion of various biologics on the market, upwards of 10 to 15 different biologics on the market, trying to, really fix this problem. And, depending on how you think about tendon problems, is it a tendon to bone problem? And that's the way Rhodium and Atrion is looking at it, at that interface. A lot of current products out there look at it as a surface of the tendon or bursal-sided problem. And I think that nothing is necessarily always right or wrong. There's different ways to think about things. But I think that we're going to explore tonight this technology and also talk about other technologies and sort of educate our audience. And hopefully we'll be able to have robust discussion and take questions from the audience during this discussion. So I'll let Brian kick it off with a little bit of background for us on rhodium and talk to us about his experience and outcomes.
Yeah, thanks everybody. Brian Badman, I'm from Indianapolis. So I got involved with rhodium. Actually, I heard about rhodium probably 5 years ago now. I saw a paper that Tony Romeo and Jed Johnson had sort of co-authored, and it was their initial sheep study. And, I had it like what Joe had alluded to. I mean, I was not happy with some of my outcomes. I tried one of the earlier popular graphs, and I actually was one of the earlier users of that. And I had problems with stiffness, had a couple people spit the graft out. So when I saw this, I thought this was different. And to I think for a lot of people, this was a little bit of a leap of faith where you're actually putting something underneath the tendon on top of the bone, which you would think would be counterintuitive to what you're trying to do. But then in speaking more so with Jed and talking with Tony about what they had done and what they had found, it really intrigued me, which really prompted me to start using it. So rhodium, it's a bioresorbable wick. It's basically a nanofiber scaffold made up of two polymers that essentially break down over about the course of about 3 or 4 months. The good thing is that what it breaks down to is a lot of it turns into like a lactic acid. And we know in terms of wound healing, lactic acid is actually something that's very favorable in terms of, tissue healing. It promotes a proper pH. and it really helps improve the biology. So when I look at, if you look at this under an electron micrograph, it looks like a sort of an interwoven fibrils. And so I look at it almost like a tissue expander. So, normally if we're doing if you believe the crimson duvet, where you're trying to get spot welds, instead of getting like little focal spot welds, if you apply this on top of the tuberosity as the cells are coming out of the bone, it almost creates like a carpet or meshwork. So instead of getting spot welds, you can almost expand your entire footprint to allow for entire healing at the enthesis, which again I thought was very intriguing. So they won the Navisi Award with the Basic Science Award for their sheep study last year at the ASCS. And again, the basic science would show that at 3 months, when they sort of looked at tendons that had the graft or tendons that did not have the graft, I believe the strength of the repair was almost 75% stronger in the sheep that actually had the graft included in the repair. And more importantly, it looked like Sharpie fiber. So it looked like actual tendon to bone healing, which again was very, I think very powerful. My experience, I've now authored 2 papers. I first started with retrospective study. I think it was powerful in the fact that we looked at 33 patients. We had MRIs on every patient, and I looked at our healing rates, and we had I reported a 91% healing rate in a retrospective cohort, and then we're currently doing a prospective study as well. So I took out my data from the 2-year registry, and I published on that, I believe, last year. Again, presented it at your meeting, Joe, at Shoulder 360. And again, at 2 years, if you looked at the 2 groups, so the group that got the graft, the group that did not get the graft, 7% healing versus a 50% retail in those that did not get the graft. So I'm a firm believer. I think this is very, I think this has greatly improved my outcomes. I use ultrasound in office, so I'm currently collecting more, data points to show that I do believe this is a strong thing, I think, to basically improve our outcomes with regards to rotator cuff healing. So.
Yeah, very, very compelling information and data, Brian. One of the things that obviously the type of graft you're using, whether it's more biological or enhancing biology versus structural, is one thing that we struggle with. And I think ideally we'd want something that has both if we could, but things have some limitations. The other thing is method of implantation. I think that's always been one of the limits of all these technologies. Is we as orthopedic surgeons, while it's safe to say what you just said made me feel that you were very smart. I know you're very much a woodworker and technician. So I know that you like efficiency and things going in quickly. So talk just a little bit about techniques of how you put it in, and how you make sure that your OR schedule continues to run efficiently.
Yeah, so I think the nice thing about this is it's very much agnostic to whatever anchor that you're using. You essentially can, it's about the size of a postage stamp. So my technique is I'll pass my sutures through the central part of the graft with a bird beak, and then I fold it like a taco, and then I shuttle it down through my lateral. I work more laterally, so I'll shuttle it down through my lateral cannula, and then I unfold it. Typically, so I usually do a double row technique. So I'll oftentimes use an all suture anchor medially. The anchor that I use has 6 sutures that I can then shuttle through the medial edge of the tendon. And so I load all 6 of those sutures on the scaffold, and then, like I said, I unfold it and then pass my sutures, and then do the rest of the repair. It literally takes less than a minute to do that. Again, we've all done some of these other grafts that I think can sometimes add more significant time to your technique, and I think this has been a very easy technique. The other good thing is that, John Levy has done another technique. I think he uses like the striker anchors, where he's has a couple of videos where he's pinned it down or held it down with a K-wire, or I'm sorry, a spinal needle. So again, I think that it's very user friendly in terms of the ability to sort of have multiple ways to sort of load it and not really slow you down.
Excellent. Well, I'm sure we'll come back to some of your points, Brian, later on in this discussion. We have with us the incomparable Bill Levine, and Bill comes to us from Columbia. He's the chairman of chairmen, and he has been very passionate about the healing of cuff and the technology we can utilize in sort of enhancing that tendon to bone healing. I'm sure he has a lot to say, so I'd like to open the stage to him.
Thanks, Joe. Thanks, Ira. Thanks, everybody. Yeah, look, this is the holy grail that everybody's been searching for decades. I've always believed, and for 20 plus years have been studying the tendon to bone interface. It never made much sense to me to be putting something on top of the tendon and then hoping it would somehow magically heal on the articular side. And so the interface between tendon and bone is the weak link. The question is it a vascular problem? Is it a tendon problem? Is it a muscle problem? The answer is probably yes to all of the above. And I think there's lots of good evidence on all three of those. So I started working, as many of you know, with Helen Liu about 20 years ago, looking at this, and have a similar scaffold, slightly different composition, but a bilayer scaffold that goes between the tendon and bone, and have shown the same exact studies, results with our animal studies that the Rodian folks did with. The big problem is, I think everybody realizes, is that when you fix a rotator cuff and look at the histology, it never recreates the enthesis, and it always looks like a big scar ball, which is probably part of the reason why it goes on to fail so often. And so if you can do something at that interface to get it more closely aligned to normal anatomy and normal enthesis, then that really is the holy grail. And so this device and others that are trying to do that, I think, are on the right path. I think at the end of the day, we have, I know we're going to talk a lot about this, Joe. What's the value proposition? What's the cost benefit analysis? How do we justify all that? You already brought up, ease of insertion is really critical, because if you add 30 minutes of OR time to what the current state of the world is, with how much pressure there is on productivity, and time efficiency in the OR. The longer you're in the OR, the more swelling, pain, etc. So lots of interesting issues, and I'm excited to be here and hear from the rest of you. But this is definitely something that we've been looking at for a long time, and I think we're getting closer. I think to really viable options that we can offer our patients that aren't just me too, aren't just gimmicky, aren't just easy to put in, but probably don't make a lot of intuitive sense or change the final outcome for patients.
Bill, what you've been working on, is that going to be commercially available? Is it commercially available? What's the status of it?
Well, that's one of the biggest frustrations of my career, is the answer to that. So, we have more data than anybody on our animal studies, and the commercialization process has been a challenge. And so we are still working on that part, but unfortunately don't have it available yet.
Got it. And so, Bill touched on this, and, it's a cost issue. So, we should, I think, be selective in who we put this in. While it'd be great to add it to everyone like a vitamin, and it's 1 cent, they're not 1 cent. And so, one of the things, Jovan, is you could talk about is selection. What are you following at this point when you're using these types of biologic augments? What's your algorithm? Who qualifies? Who doesn't qualify? How do you do it? If you could talk about that.
Yeah, I think Dr. Levine brought up some really, really amazing points. Number one is that tendon-bone interface, that ability for the tendon to really actually build Sharpie's fibers and be able to dig into that tendon. We've not been able to reproduce that with just anchors and sutures. Even with suture tapes, even with better tech, rhodium for me has been something that I've used more often than not. Again, there's a cost associated with it, but when you compare that cost to dermis or perhaps a bioinductive implant, it is far, far less. One of the holy grails that Bill talked about was, how do we get that tendon to heal truly to the bone in a way that is, what Mother Nature made for us, a tendon that has Sharpie's fibers that have dug into that cortical and cancellous bone. So on my very worst, and unfortunately my shoulder practice is mostly revision rotator cuffs or massives that were sent to me by people that said it couldn't be fixed. We've developed something called the sandwich technique, which is where we put rhodium on the bottom of the graft, and then on top, we will shuttle the acellular dermis on top of it. The rationale there is akin to what Bill is alluding to. What do we need to do to get these things to heal? We need the biology at the tendon-bone interface, but we also may have to add structure. So anybody who's ever sewed a rotator cuff that was thin, attenuated, and you pass it through with either a retrograde or integrate suture passer, and you say to yourself, man, not a great bite, not a great bite, not a great bite, not a great bite. So for me, my indications are, I think, a much wider indication than what maybe Brian or Dr. Levine would say. But I use it more often than not because I want that biology at the tendon-bone interface. And if I need to back it up, I'll put a graft on top to add not biology, but structure. Because we, at least in my humble opinion, rhodium has added that level of biology that makes me more comfortable being able to take care of a rotator cuff where maybe somebody has a catabolic state, maybe they're a smoker, maybe they're diabetic, maybe they're uncontrolled. But to me, it is a boon to surgeons that really understand the biology of tendon-to-bone healing.
So let's challenge Paul Sethi. Paul's on here. Paul, can you give me some objective idea of who you give a bio inductive implant to, or who do you use it in? Does the patient walk in and say, "Why don't I get one of these?" And you say,
so
"Well,
it's actually my question to everyone on this panel, and I'll give you my answer. But what I really want to understand is, when do I want to enhance the emphasis, or versus when do I want to enhance the bursal surface? But the best thing I have now is leaning on Patrick Denard and the Rohe score, which has not been validated. And if I can predict that someone has a Rohe score of above 7, which is going to lead me to a 30% chance or 32% chance of healing, then I feel compelled to try and add some form of augmentation, whether it's at the emphasis or whether it's on the bursal surface. I still struggle intuitively. And that would be a fun thing. But for me, it's a Rohe 7, and we're working on validating that concept.
let's go around the group here. Brian, when are you using this?
So I would argue back. I mean, I think when people say, well, we got to be selective, I think if we really dig deep into our outcomes, there's a study coming out where they looked at small to medium sized tears, and I think most people would say those are the ones that probably don't need to be augmented. But there's one of the guys working on some literature, a paper that shows that probably 30% of those that we take for granted are still not healing. So for me, because of those numbers, I mean, I use rhodium on pretty much probably 90 to 95% of my small to medium cuff tears, because again, I think accepting a 30% failure rate, revisions are not cheap, right? I mean, so I justify the added cost. I tend to use I use tensors. So when I have implications in my surgery center, I try to lower the cost by using transosseous techniques and maybe minimize my anchor burden. So I think there's ways you can lessen the cost and still add biology. So yeah, I use it probably, again, I'm a high percentage user.
Hey Joe, can I push back on Brian's articulate answer there?
Yes.
So Brian, no question, there's a higher failure rate structurally than we probably give credence to, but we certainly know that all of those patients aren't having revisions. So I think and I don't disagree with you intuitively or philosophically that if we had a perfect biologic augment, it wouldn't matter the cost, kind of the grand scheme of things. We should do it because we're going to have higher healing. But the reality is the reality. So there are going to be a huge number of those patients that have re-tears on your ultrasound in the office, whether you used a scaffold or not, who don't ever come to revision surgery. So that makes that argument hard when trying to justify that increased cost burden to society.
But Bill, Sethi here, we do know reciprocally that those.
Hey, are you on this panel?
I'm
He's on every panel.
I just curious.
You're 210. You're trying to look like me. I don't appreciate it. All right,
Yeah,
but coming back to defend Brian, we know that people who heal actually have better outcomes than those who don't heal, and it's just a limitation of the tests and the apparatus that we apply to them. So I would submit that it's not really fair to say healed and unhealed are the same.
Well, we have a nice JBJS article that actually shows that age of the patient is really the critical factor on who does well and who doesn't do well with re-tears. So you're absolutely right. If you're under 55, you definitely don't do as well. But if you're 55 to 65 or 65 to 75 and you have re-tears, you actually do as well as the cohort that heals. So it is very much age related and activity related. So I think, but your point's well taken, of course, Paul. You're intuitively, you're better if your tendon should heal, right?
Well, and I think we see that all a lot too. I mean, I think where we're weak too is getting people to come back for rotator cuff at 1-2 years if they're doing well. It's hard to get these people back, but we see that. I mean, I see these patients all the time. I'm sure you do too, where they say, well, I had a rotator cuff repair 7 or 8 years ago, and you're looking at their x-ray, it's migrated high, it's articulating on the undersurface of the acromion, and you say, well, when did you start having pain? They said, it just started hurting 3 or 4 months ago. And that's gradually failed over, that's failed longer, than when you're seeing them 3 or 4 months ago. So I think if we have, and there are multiple studies, again, like with what Paul said, that do allude that if you do have an intact tendon, that should be what we're trying to achieve.
Well, I'm glad we're having robust discussion about this. And I think partly we're to blame, right? When people have a rotator cuff repair, whether it fails or succeeds, it's such a miserable experience that they will never go through it again, whether either way.
Yeah.
So, that's a good segue to Justin Smith. If you could talk to us a little bit about where you're using it, the cost issues, what sort of you're looking at. Maybe you're a part owner of a specialty hospital or ASC. Talk to us a little bit about that.
Yeah, 100%. So I'm over in Charlotte, work for the Atrium Hospital Group. And I guess to touch on the cost aspect, that's probably the biggest barrier to my utilization right now is just, it's, sometimes expensive. Some insurers will pay for it, some won't. Those insurers that don't pay for it, if I want to use it, will kick it up to the hospital, which doesn't run quite as efficiently. So I have to be a little bit judicious, on the monetary side in terms of who I use it. Typically, I do try to follow the ROHI score, or the modified ROHI score, which basically brings in, BMI, eliminates fatty infiltration, and the bone mineral density, and looking more at just tendon size, retraction. And so I think, you kind of throw the kitchen sink at those, young laborers, large retracted tear. Maybe they have a little fatty infiltration. I think in those individuals, you need to really be cognizant of enhancing that biology and trying to get that to heal. And potentially doing kind of the sandwich technique, kind of like Jovan was saying. In those situations, I think adding something structural, be it dermal allograft, being it, some sort of, BioBrace type thing on the top, I think that can help enhance your healing ability. Yes, in an ideal world, we'd be using it on everybody. If we could get, everything to heal perfectly and we don't have to worry about it, I think that would be great. And to touch on what you guys said about, the ability to apply it efficiently and effectively, I think it's huge. Every company's got an inserter, for the onlays. Some do, some don't. You have to get, pretty fancy with whether or not you're rafting it in with your medial row sutures, whether or not you're just kind of trying to float it in there and use tissue tacks, or what are sort of staple PTS, bone anchors, and so forth. And so I think you need to be strategic in terms of what type of tear you have, where you're going to be placing it, really kind of thinking about it, not only from the clinical standpoint, but more of a functional technical standpoint to make sure that, you provide the best environment possible.
Well, appreciate that, Justin. Very well said. We have some other heavy hitters here that are not on the panel, but I'm sure they have opinions. We got Anand Murthy and Mike Redler who I'm sure are chomping at the bit to say something. One thing I want to, before I ask them, actually, Justin, can you comment on other applications that you use it in other than, I know we think just the rotator cuff exists as shoulder surgeons, but other tendons that you use it on or other areas of the body?
Yeah, so probably the most frequent is utilization, at the interface of the quad insertion site when I do a quad harvest for an ACL. Those tend to rehab a little bit slower, a little bit slower for, quad activation and so forth. So I'll put it at the interface there, and that tends to help a lot with the postoperative pain, help them heal better. I know of others that have been using it for, patellar tendon, biceps, distal biceps, Achilles, and so forth. So I think there's definitely a lot of different applications.
If I could piggyback on that, I think one of the reasons I became such a believer in the rhodium graft was my experience in the hip world. So you guys know I do hip and shoulder, and I will tell you glute tendon.
My condolences, Jovan.
Yeah. Bill, sometimes the hip calls you and sometimes you call the hip, but it called me for some odd reason. The long and the short is the difficulty as somebody who his first love was rotator cuff. I saw rhodium as a big boon there. The difficulty being a hip guy and a shoulder guy is you weight bear on your glute med. You weight bear on your hamstring tendons. And one of the biggest things I've done that has been the easiest thing that I've done is add rhodium to my glute med repairs, glute min repairs, and my hamstring repairs. It's that little extra kick of biology, particularly these folks that have degenerative, old, they were diagnosed as chronic bursitis, or, hey, you've got a pinched nerve in your back, but it ended up being a partial hamstring tear. It's remarkable the difference. My residents are writing up right now. We're taking a group of hamstring repairs for partial thickness with and without rhodium. We've got that paper coming out about the sandwich technique on glute med, glute min. But it really makes a difference. And the biggest difference that I can tell you without the clinical data in front of me is that it made my life much, much better in clinic. I had happier patients. Yet, is it expensive? It's a little bit more expensive than another suture anchor, but it's not a $5,000 graft. And that little bit of extra help where you can tell somebody, okay, you can walk on this at 6 weeks, and they're going to stress it. Some of these folks are 250, 300 pounds. It's nice to have that little extra bit of biology. Whereas, like, my arm doesn't weigh 300 pounds, but if I was getting my rotator cuff repaired, I'd want rhodium on top of it, or underneath it, I should say.
Joe, it's amazing. Ira pepped right up when you said glute med. He started like coming up to the mic. He wanted to speak. So,
let Ira speak.
All right. Hip was mentioned. Now let's go back. Okay.
Anand, what are your thoughts about what we're talking about? Your take on things. What's your algorithm? What are you doing state of the art?
Yeah, it's hard. I go back to these. What does healing mean? So, personally, myself now in my career, I want to do better. Patients do well, medium, small repairs, but I think strength, pain relief, there is another percentage point we can improve them. And when you look at MRI, post-op MRI, there's a lot of difference to what healing is. So do you get that really thick repair that doesn't have some signal? So I'm trying to use the ROHI score as well. I use it in all revisions, some type of biologics, whether it's rhodium or BMAC or something else. It's definitely, my percentage has shifted tremendously over the last 5 years. I do use that score. And we have to follow the patients, and we have to follow them radiographically too, and have a good system of following them radiographically, because if we talk about healing, that's kind of semantics. You can have a thin cuff and some, scar tissue. Is it mobile? Is it dynamic? Should we use ultrasound as well? So I think definitely more. We don't have the perfect answer, but I think everyone has to be knowledgeable of what's available now. So that's where I use. That's my take. And thanks. Appreciate it. Good job.
Mike?
Joe, I appreciate being included in this conversation, as I'm not part of the panel. There's a couple things that jump out at me. We know that with these ROHI scores that are higher, there's going to be a great challenge in terms of healing. And Paul, I would suggest that, that if you look at the original article, actually the jump is not at 7, but at 5. If you have 5 or greater, these are not healing. And so then the question is, what makes it better? Can you take poor tissue and make it better? I guess one of my big questions with this graph is it more challenging for these Sharpie fibers to go through your graft to the rotator cuff and heal? It seems intuitively that even no matter what it's made of, it's more of a barrier. I think that we need to augment. I think that biology is the name of the game here, and what we need to do is find out what is the best. And look, there are so many products out in the market. Every one that you talk about is the best thing since sliced bread. But what creates the best biology but immediate strength there as well? And I think that the immediate strength and the ability to be able to move these cuffs earlier is something that's really important. I don't know that that's actually the case with this product, but I guess my question is, if it really induces Sharpie's fibers for natural healing, perhaps that's something we can do. Brian, the fact that you're using something above and something below is awesome. I think my surgical center would show me the door if that were the case.
I think that was Justin. So it depends where you're practicing and your patient population, and I think that has a big factor in it. I think Mike, you make a good point. There's a lot of products out there, and prospective randomized controlled trials in rotator cuff surgery are very hard, very costly, and I think that it'll probably be a very long time before we could say with absolute certainty one product is absolutely much better than anything else. So I think some of it is experience. Animal data is very helpful. Atrion has done a great job of bringing animal data to the forefront. That's costly as well, but not nearly as costly as prospective, human studies.
And hey, Joe, going back to Mike's question, so the rhodium, the graft does resorb. I mean, so it's not like there for months on end. I mean, it starts to break down again into lactic acid pretty quick. And we will have our prospective data, the prospective study that we've done, which was part of my numbers, should be published by the end of this year. So.
And Mike, if I can piggyback on Brian's statement, I think the most powerful thing that convinced me of this was if you have an orthopedic surgeon that has a massive rotator cuff repair, and he comes to you to have his repair done. No worries, Joe. So the bottom line is the orthopedic surgeon came to my office and he's like, here's what I want. I want this. And I was like, this isn't a Porsche dealership. And he said, well, I believe in rhodium. I want that on the bottom. I want a dermal graft on top. I want PRP. I want this. I want that. And so you ask yourself, if it's your shoulder, it's your rotator cuff tear, and you have a large rotator cuff, what would you do for yourself? Or what would we do for our patients that have this big problem? I understand the financial burden. There's no question about that, but it is something that I personally believe in. That guy outdrove me when we golfed together, and it made me very sad because I'd fixed his shoulder for him and I couldn't hit the ball as far as him. But it boils down to, I believe in evidence-based medicine. I believe in clinical experience, and I also believe in thinking outside the box to some extent. Not to bankrupt healthcare or anything else, but if it's your own shoulder, what would you do for yourself? What would you do if that patient was your brother, sister, cousin, best friend, whomever?
Great question. Obviously, outcome is the prize that we're all looking for. And I think that the reality is there are so many different products out there trying to discern what can allow us to get the best biology of healing is still a question. And above, below, dermal, I think it was Brian said, dermal graft above, and then the rhodium below. I still will look for something that gives me immediate strength. I can move these patients earlier. I think that all we're trying to do is get the curve in our favor, where we're having less re-tear rate, better outcomes. And as Bill suggests, we know that that may not always correlate with the radiographic studies, but I think that if in an ideal world, we're going to use everything in our power to do so, that the economics of medicine as we stand today will allow us to do.
Maybe we can change just a little direction here and talk about some of the common open surgeries that we do, and we are concerned about tendon healing. Specifically, in the realm of anatomic and maybe even RSA surgery, where we're fixing the subscap, and we do worry about subscap failures. Just from the panel, are you using it for procedures such as anatomic shoulder? And if you are, when? Always, sometimes? Or what's your sort of decision tree? Maybe we'll start with Bill.
Yeah, Joe, I have not used it. The companies ask me on a daily basis to consider using it for that indication. I'm more concerned if the subscap is of questionable integrity, Joe. I've consented every patient that's having an anatomic for possible reverse. So I would be much more inclined to do a reverse where I have a predictable outcome without being concerned about, is that scaffold or that biologic augment going to actually help that concerning subscap. So interesting potential indication, but I have not used it there.
Brian?
So I have a love-hate relationship for the subscap with reverse arthroplasty. So I currently use it on my RSAs. I'm actively looking to see if it makes a difference, because I think we talk about repairing it, but I don't think we always know. I know there's a couple studies that looked at it with ultrasound, but I'm trying to do my own due diligence on my own subset, because I think if I fix it, I know for certain that not all of them heal. So I'm curious. I do believe this. I'm probably seeing anecdotally now a little bit of a difference in those that I've included rhodium on and those that I did not. But again, it's a current study. I'm pretty close to having the data to submit that. So yes, I use it on all my RSAs, and it's completely off label. I do an LTO technique on my anatomics, and I'll wedge a piece of rhodium in between my LTO, because I think it creates a little bit of a bridge, a little bit of a cheat factor. And I've got some evidence to show that my LTOs, I think, are healing a lot faster by doing that. So
Interesting. Anyone else with different opinion on the panel want to share there? I haven't yet. I do think about it, honestly. I have a hate relationship with the subscap. I don't think I love it ever. I'm always worried about the subscap. Until they're like 10 years out and they come in and they're doing great, I'm still looking, where's that subscap? How's it doing? So it does worry me a lot. One of the things that I'm sure all of you on this panel get asked as thought leaders is, what's the price point that something needs to be at for it to make sense, right? Because it could be 10,000, it could be 6,000, it could be 4,000, it could be 2,000, it could be $1, right? Obviously, the cheaper the better. But is there a price point that you won't even go to your ASC or hospital and talk to them about it, unless there's absolutely compelling data that you have to use it? Is there a price point that you consider at your facilities? We'll start with Jovan.
Yeah, Joe, I would say it should be a little bit more expensive than an anchor. If you can get to that price point, to me, that makes sense. Again, the integrity of the primary repair is critical. We have to have a solid primary repair, which is why I tend to be a single row guy, triple loaded. I do a Mason Allen. I don't tend to favor double row because of the type 2 failures. But if I can add a rhodium with a single row, I would prefer that over a double row with, let's say, a dermis or a different graft on top of it, porcine, whatever you may be. But I think that's the price point that makes the most sense, is just a little bit more expensive than one more anchor.
Justin, do you have like a magic sort of, when you go to the administrators at Atrium, what you're allowed?
Yeah, it's basically, whether or not there's a carve out for implants with certain insurers, depending on that carve out. Typically I'm doing, a double row, 2 medial, 2 lateral for a lot of these larger tears. And so if that price point comes in above whatever the carve out is, I pretty much can't use it. And so that usually ends up being about $5,000. And so I will potentially do, a single medial, 2 lateral, or kind of change my construct to be able to use it in certain situations. And to go back to your earlier point, my initial introduction with rhodium was through Michael Kissenberth, one of my mentors, using it for the subscap and anatomics. the subscapularis anatomic obviously is super stressful, and that's the crux of everything. And so getting that to heal and just adding a little something to ensure that, I think, is a big deal.
Ryan, you use it pretty liberally. Have you had any issues as far as in your facilities, people looking at the cost associated with your cases compared to, say, some of your partners?
No, but again, I try to be somewhat. I try to bring the cost down of anchors, and I'm very conscientious when it comes to like other stuff. I use tensor. Again, I'll do sort of the transosseous technique where you're just paying the cost of sutures. So that's been a big, huge means for me to sort of implement, using rhodium a little bit more liberally. So and going to your cost point, I think, $1,000, $1,500, I think that still keeps me in a positive ballpark. The problem I find is that some of these companies will tell you the cost of their graft, but then they'll sort of sneak in the other stuff, like, the cannulas, an extra $500, and then the staples are an extra, $200 a piece. So all of a sudden, the graft that you think might be $1,800 when you throw all the widgets in, now you can get up to like $3,000, and then you're upside down very quickly. So so I'm always a little bit more sensitive when people tell me the cost of, to make sure it's all inclusive.
I would also mention too, the hospitals upcharge a ton on these things. I've been auditing some of my cases. One of my patients came up to me saying like an ACL cost them like $100,000. I'm like, how is that even possible? And they're upcharging like, a factor of 10 for just every sort of implant you put in. And so definitely something to be aware of, what your patients are being charged on the back end.
Hey, Joe.
Yes.
I think interesting conversation. And, if you took a step back from Justin and Brian's comments, I think you kind of look at this and say, this is not making sense to me. Because if you're a rotator cuff repair surgeon and you believe there's a certain way that you fix rotator cuffs, and now you have a biologic augment that hopefully is going to improve the technique that you're comfortable with and that you've been using, then you would just add that augment to your normal routine. But I just heard Justin and Brian talk about changing their techniques to accommodate the scaffold because of the cost analysis. And that's worrisome to me, because now you've added a whole new set of variables. It's hard enough doing prospective randomized trials or even retrospective studies, but we're changing a bunch of different variables all at once. So it is an interesting concept, and one that I think, as all of us know as surgeons, our goal is hopefully with new technology to just make your technique that you've been doing better, but to not change it fundamentally. So it's just an interesting sidebar from both your comments. And I understand why you're doing it, because you're trying to be, cost conscious. But I wonder if that's going to add a whole new set of concerns for your typical repair strategies.
Yeah.
One thing I would throw in there quickly is that, at least at our surgical center, implantation of a biocomposite implant is often reimbursed. And I think obviously you need to look at where your different insurance carriers are as well. But adding that augmentation does not need to be a loss leader, as long as it's well documented as an implant within your case of surgery. And that's certainly been our experience, which sort of liberalizes not to change your technique, but to add augmentation for these cuff tears at risk.
Yeah, I want to stress. So my adoption.
Brian, go ahead.
Oh, I was going to say my adoption of more of the transosseous technique was more to try to get rid of anchors, because I'm old enough now where I'm seeing patients come back with these resorbable anchors in their head, and they've got big, huge cystic changes. So I actually met with Brett Sanders, and that was my whole adoption for the trans. So I'm still, I think, on a learning curve for using transosseous technique. But I do think there's value in that. And it's a huge value proposition when you're privately owned ASC, where you can eliminate the anchor burden. And I think there is good data to show that you can actually improve your cuff healing by doing that. So again, I try to go back more old school, but it's still newer way to fix it.
Just to piggyback, Brian, on Dr. Levine and Dr. Redler's comments. So I'm extremely fortunate because Crystal Clinic was the last physician-owned hospital to get its own license. So I do these all at the hospital. We have our own billing company. So I know that if I'm using an implant, what the cost is, what it's going to reimburse. To Dr. Redler's point, I don't change my technique if I'm using rhodium. I'm still doing the same thing that I've always done. I'm adding it for a biological purpose, and to his point, documenting it. And Dr. Levine's right. To study the analysis of rotator cuff healing is so difficult because there's so many variables. Do you do a chromioplasty? Do you tense the bicep? How many sutures did you put through the tendon? How large are anchors? Are they 4.75s? Are they 5.5s, 6.5s? What was the quality of the bone? There are so many unbelievable variables that I think all of us have our techniques and our go-tos for either small, medium, large, or massive cuff tears, for repair of the subscap, et cetera, that I have fortunate ability that I don't have to adjust because I have a system that allows me to use those implants where I know they can be reimbursed. And I think that's important for everybody to understand on the panel.
Yeah, I mean, I think that some companies have developed this technology on anchors, and I think that eventually, if that develops to be on an anchor, that's the ultimate sort of non-disruption of your technique if you use an anchor system. To Brian's point, transosseous is great. I've been down that road and I've helped develop the transosseous system. The problem is, which is Bill's experience, commercialization, marketing, distribution is very challenging when you're competing with an anchor-based world. And companies do not want to hear that you're going to get away from anchors. So all these things have these inner sort of struggles that you have to figure out as far as how to make these things work. So those are my thoughts on that. Other thoughts from the panel on this? So Bill, you're in New York. Obviously, they get 7 opinions. They come to you, and you describe to them. They let's say they're a Rohi 6 patient, wearing Prada, and is looking at their watch when you walk into the room because you're 4 minutes late, and they want the best repair done by Bill Levine. What are you going to offer them? This is a superior cuff tear. It's supra into infra retraction, mid-humeral head level with stage 1 atrophy.
I did 3 of those today, and none of those had augments. So one had single row repair because of the tear configuration. 2 had double row repair because of the tear configuration. So I still let tear configuration in many ways shape which type of repair strategy that I pick. And I usually use augmentation when I'm concerned about the tissue integrity. We do look at the Rhodey score as well, as Paul nicely brought up. But I'm not using augmentation right now routinely.
And are you using anything locally like the biceps? Are you using that for any augmentation, swinging that around into your cable reconstruction? Are you doing any of that that's available and free?
I'm using that for more of the irreparable supra kind of scenario. So as a biologic superior capsular reconstruction technique, I think that makes sense to me and is much cheaper than putting a dead piece of human skin there.
Bill, if I could ask a question that is rather controversial.
Go ahead.
So you've been doing this a long time. We all know that you are a leader in our field and one of the best surgeons on planet Earth. Do you think it's more important to get a cuff repair that's anatomic, that is well secured to the greater tuberosity, or if the subscapula is involved, the lesser tuberosity, than it is to augment that?
Jovan, I'm not sure I understand the question, so just help me understand where you're going again.
Do you think the most important factor to healing is a superb repair that has excellent purchase of the tendon, excellent bone quality, or do you think that you can get away with a lesser repair with an augment on top of it? Because I have my own opinion on this, but I want to hear from you.
I love the question. I don't think I have it would certainly be a level 20 opinion because I don't have evidence. I think we make mistakes for sure, and this may be where you're coming from in trying to over tension the tendon which is already shortened and contracted in many situations, and trying to bring it all the way across. As you know, Steve Snyder has always said, all we have to do is repair it to the medial footprint, and then you get creeping substitution, if you believe that, with a crimson duvet, etc. So I don't know if I believe that or not. I know that I certainly do repair medially on occasion. If the tendon, when I take the non-penetrating grasper and bring the tendon over and it very nicely comes to the lateral footprint, I see no reason to not use the entirety of the footprint. And then whether you do single or double row repair is probably dealer's choice. So I guess bottom line is, I think that we probably create those type 2 tears, not just from a vascular insult, but from an over-tensioning insult by trying to bring it too far over the footprint.
What is y'all's opinion about some of these grafts kind of acting as, humeral head depressors, using some of these? I know you mentioned, dead human dermal tissue, but, kind of referencing back to, the original SCR, Miata's fascia lata, but now we're talking about, tuberoplasties and acromioplasties with, tissue to kind of, and then balloons and so forth. I guess, what is y'all's opinion about some of these more structural grafts kind of acting in a similar fashion?
Justin, you just brought up a whole nother webinar, man. That's like part 2. Great.
There you go.
Joe's biting at the bit. I'm just telling you that right now. I'm going to say one thing though, and Sharif Bachet, I think at Joe was at your meeting, talked about that they looked at some of these dermal grafts and they biopsied them for repeat shoulder arthroscopy, and they said, newsflash, it's still dead skin. It didn't change at all. So I'm not sure that ultimately ends up being your best graft.
Yeah, and I think we're talking about different potentially problems. I mean, I think you're talking about, Justin, maybe more irreparable tears that we're trying to manage for pain. And I think most of the focus tonight has been about potentially reparable tears and improving their healability and function. So, but I agree. I mean, I don't know the answer to that. I mean, I know what my bias is and what I've used and what my experience is with, but and nothing's permanent though. I mean, even biologic tuberoplasty, I don't think it just stays there. I mean, I know there's MRIs that show it's there, but over time it braids off and it's
the one thing, Justin, the one thing you'll find out when you get gray hair, like some of us on this, is that usually when you see something that's being talked about now, just go back and look in the historical archives, because you'll find John Fenlon's tuberoplasty from 50 years ago. You'll find pretty much everything from a long time ago. So it's very rare that we have truly disruptive technology and disruptive innovation. Usually it's a retread of something that's already come and gone and failed, and then gets reinvented with a fancy new name 30 years later.
Metal on metal hips is a great example. They were
just go down the line.
Yep.
Great. I think we've exhausted our panel, and I think we've come up on time, if I'm not mistaken, Ira.
Yeah, no, absolutely. This is great. It was a pleasure that I was able to channel my moderating through you, Joe. It was great. And I want to thank everybody, Atrion, this amazing panel, the new panelists who came on. I'll have to post on LinkedIn everybody's face who talked. This has been an amazing session. I am trying to get honorary membership in ASES because I've listened to all these shoulder talks completely. been at Shoulder 360 and others. But anyway, I want to thank everybody for coming tonight. We love doing these at JOEI. We think this is a great contribution to the community, and we all learn a tremendous amount from each other on this. So thank you very much for tonight. Joe, thank you, and I hope all the panelists, just phenomenal session tonight.
All right, thank you for having us, and
Thank you.
to Atrion for sponsoring this.